The oxygen and carbon dioxide content of blood each have different effects on pulmonary and systemic circulation. This is an important concept to understand, as it will help you reason through situations where you may not have an immediate answer. Now let's look at oxygen. Systemically, a decrease in alveolar PO2 shunts blood away from less ventilated regions of the lung. This leads to vasoconstriction and pulmonary hypertension, which we'll discuss in a bit. Another important concept to understand is when and how gas exchange is limited by either diffusion or perfusion. In healthy individuals, gas exchange is limited by perfusion. So what does perfusion limited mean? Here, gas equilibrates early along the length of the capillary, and you can only get more oxygen into the blood by increasing blood flow. In addition to oxygen, CO2 and nitric oxide are perfusion limited. You can also see this visually represented by the figure on the left, where the pressure of a given gas in the blood and in the alveolar air reach an equilibrium quickly, and no further gas exchange occurs while that same blood is in the pulmonary capillary. Contrast this to the figure in the middle, where gas exchange is limited by diffusion. As you can see, blood is not in the pulmonary capillaries long enough to reach equilibrium with alveolar air. So when do you see this? You can see this with carbon monoxide and with oxygen in pathological states, in which the gas either has a smaller surface area to diffuse across, as in emphysema, or has to diffuse across a further distance, such as with pulmonary fibrosis. You can see the same concepts here on the right with oxygen. In exercise, the equilibration occurs late along the length of the pulmonary capillary. So what's going on? This is because the velocity is increased through the capillary bed, so there is less time for oxygen to equilibrate. Pulmonary hypertension is super high yield, so make sure you start this topic now for later review. Pulmonary hypertension is currently classified into 5 groups, but it's still useful to think of pulmonary hypertension as primary or secondary. So what is primary pulmonary hypertension? Primary mostly corresponds to idiopathic or hereditary pulmonary arterial hypertension. It most commonly occurs in women ages 20 to 40. One major cause, although not the only cause of primary pulmonary hypertension, is an inactivation mutation in the gene for bone morphogenetic protein receptor type 2, or the BMPR-2 gene. This is a member of the TGF-beta signaling family, and its normal function is to inhibit vascular smooth muscle proliferation. You can think of secondary pulmonary hypertension as being caused by anything else. So what are those conditions? Well, they include COPD, mitral stenosis, we'll toss in CHF, recurrent thromboemboli, anything that causes a left to right shunt, sleep apnea, living at a high altitude, and certain drugs such as the notorious fen combination for weight loss that are no longer available, and cocaine. Think for a moment about the underlying disease mechanisms and how each might contribute to the development of pulmonary hypertension. For example, what causes a left to right shunt, and what is the underlying pathophysiology? Well, you typically see this with a ventricular septal defect, pulmonary ductus arteriosus, or an atrial septal defect. And these heart defects cause more blood to have to flow through the pulmonary circulation to get the same amount of oxygen to the body. As a consequence, this increased blood flow physically injures the endothelium via shear stress, causing them to become thicker, which increases pulmonary arterial pressure. So how do you treat pulmonary hypertension? Well, first you try to take care of any of the underlying secondary causes. Other treatments that you may have learned about include calcium channel blockers, epoprostenol, bosentan, which is an endothelin receptor antagonist that we'll talk about later on, and multiple phosphodiesterase type 5 inhibitors like sildenafil, better known as Viagra. Over time, you may get cor pulmonale and right ventricular failure. On physical exam, you would see jugular venous distension, edema, and hepatomegaly. At the end of the day, some patients may ultimately require a lung transplant in order to survive. Now we're going to discuss pulmonary vascular resistance. The key here is to understand the relationships among resistance, pressure, and flow. Does this concept sound familiar? This is pretty much the resistance, pressure, and flow fact discussed on page 255 of the cardiovascular physiology section, so you might want to go back and check it out. Now, it's not necessary to memorize the equations, but you do have to understand the relationships. As you can see here, resistance equals the pressure gradient divided by flow. In this case, R is pulmonary vascular resistance. The pressure gradient, or delta P, is the difference in pressure between the pulmonary artery and the left atrium, and Q, or flow, is cardiac output. Pulmonary vascular resistance is directly proportional to viscosity, which is represented here by the Greek letter eta, and inversely proportional to radius raised to the fourth power. This means that radius is the most important contributing factor to resistance, so it makes sense that the pulmonary arterioles contribute the most to pulmonary vascular resistance, because they have the least total cross-sectional area in the pulmonary circulation. Let's talk about oxygen content in the blood. Normally, 1 gram of hemoglobin binds 1.34 milliliters of oxygen. Assuming a normal concentration of hemoglobin of 15 grams per deciliter, how much oxygen is bound to hemoglobin? The answer is about 20.1 milliliters of oxygen per deciliter. Now, it's no surprise that the absolute oxygen content of arterial blood decreases as hemoglobin falls. However, you won't be able to tell that from the oxygen saturation in the arterial PO2, which can still remain high. Now, what did we talk about a couple of minutes ago that can decrease arterial PO2? Remember, chronic lung diseases like pulmonary fibrosis and emphysema can limit diffusion of oxygen and decrease arterial PO2. Now, bonus question. What can lower venous PO2, even if you have normal arterial PO2? The answer is exercise, and we'll talk more about exercise physiology at the end of this section. The alveolar gas equation is used to calculate the alveolar arterial gradient, or the AA gradient, which is useful when trying to figure out the cause of hypoxemia, which we'll discuss next. The good news is that you can estimate the PaO2 by knowing the PaCO2 from the arterial blood gas. So what's the normal PaO2 for a healthy adult individual at sea level? Well, the normal PaCO2 that you'll see on ABG is about 40 millimeters mercury. So divide by 0.8 gives you 50, and subtract that from 150 gives you a PaO2 of 100 millimeters mercury. If you see an AA gradient that's greater than 15 millimeters mercury with hypoxemia, you should be thinking about some sort of right-to-left shunt, VQ mismatch, or a diffusion limitation problem, as we just discussed. This is a useful framework for understanding the various scenarios in which not enough oxygen gets to the tissues. Hypoxemia occurs when the partial pressure of arterial oxygen is decreased, and it can be caused by things that decrease the amount of oxygen that enters the lung with a normal AA gradient, such as high altitude or alveolar hypoventilation, or by things that prevent the oxygen in the lungs from entering the blood, i.e. a high AA gradient, such as VQ mismatch, impaired diffusion, or right-to-left shunt, which we talked about earlier. So what would be an example of a right-to-left shunt here? Well, it could be anatomic, like tetralogy of Fallot with a VSD, or physiologic, like pulmonary edema. Hypoxia is the condition in which there is decreased oxygen delivery to the tissues, which can result from hypoxemia that we just discussed, or from other factors such as decreased cardiac output or carbon monoxide poisoning. So here's a question for you. What's the most common cause of decreased oxygen content in the blood in the setting of normal oxygen saturation? The answer would be anemia. In addition to carbon monoxide poisoning, we should also add methemoglobinemia. As you recall, it causes a functional anemia because the methemoglobin does not bind oxygen as well as regular hemoglobin. Finally, ischemia is a loss of blood flow to a particular tissue or organ, and thus the absence of oxygen availability. This can be caused by something that impedes blood flow, such as an embolus or clot, or by decreased venous drainage, since if blood can't exit a capillary bed, then no blood can enter it either. VQ mismatch is a critical concept for the boards, and we've already alluded to it a couple times during this talk. In this concept, V equals ventilation, while Q stands for perfusion. The ideal situation is that the ventilation is perfectly matched to perfusion, and thus a VQ ratio of 1. So what happens in the typical person? The average person maintains a ventilation of 4 liters for about every 5 liters of blood flow, with an overall VQ ratio of 0.8. However, in the lung of a standing person, there's variation in the VQ ratio thanks to gravity. Basically, ventilation is much greater than perfusion at the apex of the lung, where you can see wasted ventilation. The wasted ventilation is the reason oxygen-loving bugs like tuberculosis tend to end up in the apex. Perfusion, on the other hand, is greater than ventilation at the basis of the lung, so you get wasted perfusion. As you can see, the perfusion is a function of the interaction between pulmonary artery pressure, pulmonary venous pressure, and alveolar air pressure. It's worth noting, however, that both absolute ventilation and absolute perfusion are greater at the base of the lung than at the apex. However, gravity increases perfusion more than ventilation. So let's talk about the extremes of VQ mismatch. A VQ mismatch of 0 represents a complete shunt in which there is perfusion but no ventilation. So what are some examples of this? Well, you see this shunt with status asthmaticus and airway obstruction, and in these cases, increasing oxygenation does not really improve arterial PO2. Dead space ventilation represents a VQ mismatch approaching infinity. In this instance, there is ventilation but no perfusion. So what's a clinical example? Well, a massive pulmonary embolism would be the classic example. In this case, giving the patient 100% oxygen should improve PO2, except the blood's not really going anywhere. So far, we've talked quite a bit about the role of oxygen in pulmonary physiology. Just as important, however, are the mechanics of carbon dioxide exchange. From the acid-base physiology material in the first aid renal physiology section, you'll remember how the lungs and kidneys work together to maintain homeostasis in the human body. Carbon dioxide is transferred from the tissues to the lungs in three forms. The majority of the carbon dioxide enters the red blood cell and is converted to carbonic acid by carbonic anhydrase. The hydrogen ion dissociates and you're left with bicarbonate. The remainder is either bound to hemoglobin as carbanohemoglobin or dissolved CO2. Now let's talk about some key physiologic concepts involving CO2 and oxygen transport. The Haldane effect describes the phenomenon in which carbon dioxide is released from red blood cells. In the lungs, oxygenation of hemoglobin causes dissociation of hydrogen ions, which can then combine with bicarbonate to form carbonic acid, which then splits into carbon dioxide and water with carbonic anhydrase. So what's the bottom line? Well, this is the opposite of what happens in the peripheral tissue, and basically the greater presence of oxygen in the pulmonary circulation causes carbon dioxide to be released, where it can subsequently diffuse into the alveoli and be exhaled. As we alluded to earlier, the Bohr effect is when the increased hydrogen ion concentration in the peripheral tissue shifts the oxygen hemoglobin dissociation curve to the right and favors the oxygen unloading to the tissues. Finally, I'm going to talk a bit about the chloride shift, which is not really discussed in first aid. When you make a lot of bicarb, it has to go somewhere. The red blood cell can exchange negative bicarb ions for negative chloride ions to maintain electrical neutrality. And like the hydrogen ions in the Bohr effect, the chloride ions also have a negative allosteric effect on hemoglobin, causing it to dump oxygen into the peripheral tissues. These are some super high yield concepts that we just discussed, so you should rewind and review this video until you completely get it. Got it? Great. This topic is high yield because the physiology is so clinically relevant and testable, so be advised that this can definitely show up on the exam. Alright, so you probably already know that athletes often train at high altitudes for better speed and performance. You get increased minute ventilation as there is less oxygen content in the air at higher altitudes. Gradually, the body adapts to altitude by producing more erythropoietin, which increases the hemoglobin and hematocrit in response to chronic hypoxia. As we mentioned earlier, there is also an increase in 2,3-biphosphoglycerate, which does what again? It decreases the affinity of hemoglobin for oxygen by stabilizing the T or TOT form of hemoglobin, which promotes unloading of the oxygen to the tissues. At the cellular level, you see more mitochondria and the concentration of mitochondrial enzymes to improve efficiency of cellular oxidation. Once you go from acute to chronic hyperventilation, you get a respiratory alkalosis, which is countered by an increase in renal excretion of bicarbonate. As you remember from the first aid renal pharm section, we give acetazolamide to treat acute mountain sickness by forcing the kidneys to waste bicarb. Finally, from a cardiovascular standpoint, chronic hypoxia leads to pulmonary vasoconstriction, and over the long run, this can cause pulmonary hypertension and right ventricular hypertrophy. Finally, I've mostly talked about chronic changes in the lungs, so I'll just mention that in addition to acute mountain sickness, a rapid increase in altitude can lead to pulmonary and cerebral edema, and this is thought to be secondary to increased arterial and capillary pressures and increased capillary permeability. So let's wrap up respiratory physiology with exercise. So what happens when you exercise? Well, obviously there's increased oxygen consumption and increased carbon dioxide production. Of course, the ventilation rate goes up to meet this increased oxygen demand, and more specifically, there's an increase in both ventilation and perfusion, and the VQ ratio from the apex of the lungs to the basis become more uniform. So exercise causes vasodilatation of the apical capillaries, so the pulmonary blood flow you see occurring in zone 3 occurs in the other zones as well. As cardiac output increases, there is a proportional increase in pulmonary blood flow to support efficient exchange of oxygen and carbon dioxide. Interestingly, there is no change in PaO2 or PaCO2 because of the efficient gas exchange, but there is an increase in venous carbon dioxide content. Finally, there's a decrease in pH because of lactic acid production. So to recap, what does this decreased pH do to the oxygen dissociation curve? It shifts it to the right, remember? This allows the hemoglobin to unload the oxygen in the tissue where it's needed the most. Finally, the exercise physiology principles that we've just covered can also be extrapolated to other situations in which the body is subjected to acute stress, such as during illness or after surgery.